So good evening, everyone. My name is Amar Swali, and I am the consultant physician and nephrologist working with Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania. Welcome to series 114 of the AHN Fireside Chat. Allow me to introduce to you our most prolific speaker in the Fireside Chat series. That's Professor Santosh. He's been very regular, always taking time out with us. He's previously given us a two-part talk on neurotherapies in glomerulonephritis, the assessment of a renal mass, the neuroconcepts in treatment of anemia in CKD patients with iron deficiency, implementing sustained low efficiency dialysis SLED in the ICU, and slow continuous renal replacement therapies, videos for all of which are available on our YouTube channel for your viewing in the AHN Fireside Chats. With that, I'd like to hand over to Dr. Lloyd to introduce his good friend, Professor Santosh. Dr. Lloyd?
Yeah, thank you, Amar. Thanks very much, Santosh, for coming on again. So many times. I think you're the most, you're the person who's come on the Fireside Chat most often. Thank you for your time. And it's indeed a pleasure to have one of my real good friends from Vellore, where both of us trained together at the same institution. Of course, I was a few years senior, very many years senior. So Santosh has been the head of nephrology at CMC Vellore. Currently has just stepped down, but is the professor of Unit 1 and holds a lot of responsibility in India in number of aspects of nephrology. He trained at CMC Vellore, MBBS, MD, DM nephrology, then did a fellowship at the University of Toronto, and then has done a lot of work in terms of training, teaching, because Vellore is the #1 center in the country. He's got 6 nephrology fellows right now, including 1 transplant fellow, and I think an intervention fellow too. I think, Santosh, I'm not too sure. I think maybe an intervention also coming up, or he's already there. He's on the editorial board of numerous journals, both India and outside. He has numerous administrative responsibilities, being the head of nephrology, a PhD guide. He's an examiner, MRCP, DM, DNB, Indian Society, a member of the South Asia Regional Board, ISN, a huge number of responsibilities, and a review of number of journals, has been on the teaching front in numerous conferences, and has a large number of publications, which I'm already not going into right now. So with this, I would leave the floor to you, Santosh. Thank you very much for coming on again, and we look forward to your session today.
Thank you very much for a very, very kind introduction. The topic today is talking about HIF-PHIs, the newest kid on the block for anemia management in CKD. This picture is the foyer of our new campus. It's a large foyer where as soon as you enter, it's on the left-hand side. This shows, this is our founder, our missionary, Dr. Ida Scudder, on her bullock cart, taking medicine to the masses where there was no healthcare available. And this is the town campus hospital with our chapel right in the center and the cross on the top. And the whole thing is actually made of iron pipes. Very interesting, nice architecture they've done. For those who've not come to Vellore, this is where we are now, the new campus. It's got a large entrance and the patients have got a lot of place to sit. The care remains the same, but the patients are very happy because of space, and this is the bird's eye view. That much for introduction to Vellore, and welcome to all my friends in Africa. It's a joy for me to be back in Africa. I haven't been here since the COVID time, been there since the COVID times, but it's good for us to meet up virtually. So coming to the topic per se, before HIF-PHIs came into the market and became clinically available, the available treatments for anemia and CKD were blood transfusion, which we dreaded and we didn't want to give, and we gave it only out of necessity. We gave iron supplementation, which we talked about earlier, intravenously or orally. Dialysate iron isn't available in our country yet. And the erythropoiesis stimulating agents, erythropoietin, dalpoietin, and etc. Very briefly about the physiology, erythropoietin binds to its receptor on the surface of erythroid progenitor cells in the bone marrow and other places, and that serves as a stimulus for red cell proliferation, survival, and differentiation. Erythropoietin is produced normally in our bodies from the fibroblasts like interstitial peritubular cells of the kidneys and a little bit elsewhere. The most important factor regulating the expression is the HIF or the hypoxia-inducible factor system, which activity of which depends on tissue oxygen. Hypoxia anemic tests the stress the HIF-1 binds to the erythropoietin gene and activates expression. There are two subunits of which the 1 beta is constitutively expressed and the 1 alpha is absent in anomoxia. But then in low oxygen settings, it accumulates, translocates to the nucleus, binds to HIF-1 beta, and then binds to the DNA sequences of the hypoxia responsive elements, and the action of erythropoiesis happens. So upregulation, downregulation of these and is what happens in real life. The other genes to remember and keep in the back of our mind are that are activated by the HIF complex are transferrin receptor, VEGF, and endothelin-1. VEGF and endothelin-1 we need to keep in mind as we go along. So there are a few other things which I won't talk about. So at a normoxic condition, after action is no longer required, HIF alpha is degraded but is hydroxylation at its two proline residues, and from which we get the enzyme, and by the enzymes proline hydroxylase enzymes, and that's how we get this PHD enzymes or the proline hydroxylase domain enzymes. There are 3 isoforms of which PHD2 is the most important one, and once it is hypoxylated, it binds to the E3 ubiquitin ligase 1 HIF-lindo, and then together there is proteasomal degradation and the HIF is lost. So in CKD, I'll come back to this, what happens in CKD in the next couple of slides. So in CKD, erythropoietin levels are inadequate and the deficiency starts early but becomes severe when the GFR less than 30, and it's estimated that the GFR is less than 15, a tune of 90%, close to 90% could be having anemia as defined by the WHO standards. So there's absolute erythropoietin deficiency and or errors in EPO sensing, maladaptation, and you don't have enough erythropoietin being available. So it's also shown that CKD the increased inflammation and a blunted rather than abolished mechanism of erythropoietin production due to the ongoing inflammation. So in hypoxic conditions, which is what is exploited by the drugs, in hypoxic conditions, the action of this enzyme is prevented and the HIF-1 alpha is stabilized, translocated to the nucleus, and this pathway of constant exposure upregulation is what is exploited by the drugs, the HIF-PHIs. So very simply put in this picture from the American Journal of Nephrology issue 2017, you either have degradation or you prevent the degradation and you can have coordinated erythropoiesis. So now switching gears to talk about the studies that have been done, which is what will constitute the next major chunk of the presentation. The first drug to be studied was roxadustat. It came out as early as 2019 in New England Journal of Medicine. 2 articles came out, both in patients on dialysis as well as those not on dialysis. So in the patients undergoing long-term dialysis, the study was done in China with random allocation of patients to roxadustat or erythropoietin alpha, that the EPREX, Janssen-Cilag brand, for 36 weeks, and they gave parenteral therapy only if rescue therapy is required. And the mean primary endpoint was a mean change of hemoglobin weeks 23 to 27, the non-inferiority design. Of the 305 patients, there was a 2:1 roxadustat to erythropoietin. And what they found is the hemoglobin remained stable, rose and remained stable in these patients who are either on erythropoietin or roxadustat, meaning the drug does work. There was a bit of concern about numerically more hypokalemia in the roxadustat group, and the upper respiratory infections also a little bit more in the roxadustat group. Hypertension was more in the erythropoietin group. This is the preliminary study 2019 in hemodialysis patients. The same issue contained another article from the same center on roxadustat for patients who are not getting dialysis. Here they were given 2:1 ratio of non-hemodialysis patients, they give them non-hemodialysis CKD patients, give them either roxadustat or placebo. So this is not erythropoietin, this is placebo again. They were all given parenteline only as a rescue therapy, and after the trial was over, they were all given roxadustat, and they looked for mean change of hemoglobin a little earlier, 7 to 9, again a non-inferiority design. And I see, and as you can see, the drug seems to work against placebo, meaning there is an increase in the hemoglobin in these patients. And they also noticed some additional benefits of reduction in total cholesterol, and hyperkalemia and metabolic acidosis were more in the roxadustat group. This next study on roxadustat came out the same year in the American Annals of Translational Medicine, again from Beijing. They looked at 3 studies combining patients who got roxadustat or placebo, and in a systematic review and meta-analysis on non-dialysis dependent CKD. And they looked at other things like hepcidin, ferritin, iron saturation, iron indices, total iron binding capacity, diarrhea adverse effects, and severe adverse effects. And no surprise, compared to placebo, the hemoglobin improvement favored roxadustat. Apologies for the spelling mistake. They also found, they also looked for reduction in hepcidin, which wasn't so obvious except in this subgroup alone. They looked at the reduction in ferritin, which seemed to be constantly there in all the groups favoring roxadustat as opposed to placebo. The increases in total iron binding capacity and a decrease in the transferrin saturation all favored roxadustat. The adverse events were kind of in the middle, not favoring either group, although numerically they were a little more or less in the various styles. The 2021 had a trial called the Himalayas of roxadustat in patients who were incident dialysis patients, and published in the Nephrology dialysis transplantation issue. And that was a phase 3 open label erythropoietin alpha controlled trial in which they gave incident hemodialysis or peritoneal dialysis patients who had a hemoglobin of less than or equal to 10 grams, and looked at mean and primary endpoints of a mean hemoglobin change from baseline over weeks 28 to 52, almost a year, regardless of rescue therapy, and the percentage of patients achieving hemoglobin responses between week 1 to 24, and with a non-inferiority margin of 15%. The groups are equally numbered, 422 and 421 respectively. I put up the pictorial abstract, which show that no surprises. The mean change from hemoglobin was the same. Adverse events were comparable, and the conclusion was that roxadustat was efficacious with an acceptable safety profile as compared to erythropoietin in incident dialysis patients. The Olympus trial was a trial which came out in the JSON in 2021 in patients who were not on dialysis, and this was a double-blind phase 3 trial on patients got roxadustat or placebo, equal numbers of a little less than 1,400, stage 3 to stage 5. All of them had hemoglobin 10 grams, and they gave thrice a week roxadustat or placebo, and no surprises, the roxadustat was better than placebo in improving the hemoglobin over weeks 28 to 52. In iron replete as well as non-iron replete patients, this drug seemed to work, and the mean hemoglobin by visits also favored roxadustat compared to placebo. The proportion achieving hemoglobin response, no surprises, also favored roxadustat. In the patients who had elevated hsCRP, those who had inflammation, subclinical inflammation, roxadustat also seemed to be the drug better than placebo in this group. The cumulative probability of rescue event or RBC transfusion, again, no surprises, favored roxadustat. The adverse events were not very different in roxadustat compared to placebo. As you can see, the percentages are kind of similar, and there was no difference. The adverse cardiovascular events, they specifically others noted that the percentages were and were not very different from each other. Although numerically they seem to be more. The three RCTs were pooled together, the Andes, Alps, and the Olympus, and the pool analysis came out in the CGS in 2021. And this all looked at the mean hemoglobin change from baseline and primary cardiovascular endpoint, as well as the composite of the major cardiovascular events like major cardiovascular events, all-cause mortality, myocardial infarction, stroke. And secondary safety endpoint was MACE plus, that is major cardiovascular endpoints plus ancillary angina and heart failure requiring hospitalization or all-cause mortality. So putting all this together, there were a little less than 4,300 patients with baseline characteristics comparable with a hemoglobin of 9.1, mean GFR was 20, and compared to placebo, the hemoglobin seemed to rise by 1.9 gram compared to 0.2 in placebo, and the reduced number of RBC transfusions and the hazard ratio clearly favoring roxadustat as being useful in non-dialysis patients. There were no increased risk of MACE or MACE plus increased mortality or the individual MACE plus components. So the mean hemoglobin was also understandably better in the roxadustat group. I will not belabor the point, just to show that the results are all comparable. Safety data also showed efficacy. The pooled non-dialysis population, as well as the MACE plus, the same things which I had said in the text form, but clearly shown to be equal in both the group. In different subsets as well, the safety was clearly maintained. The innovate study of vadadustat. So we're changing molecules. Vadadustat was the next molecule study. It came out again in the New England Journal of Medicine 2021 in patients undergoing dialysis. This is a randomized open-label non-inferiority phase 3 trial of vadadustat versus darbepoetin alpha. The other one was erythropoietin. The primary safety endpoint was time to event analysis of first occurrence for major cardiovascular event, pooled across the trials of a non-inferiority margin, and secondary safety endpoint of a first occurrence of MACE plus hospitalization for heart failure or thromboembolic event. There were other secondary endpoints of change of hemoglobin. So here, compared to roxadustat, here the primary and secondary, here the hemoglobin change became a secondary endpoint. So the patients, there were 3,900 odd patients received vadadustat or darbepoetin, and of which 369 were incident dialysis patients, and 3,500 were in the prevalent dialysis patients. So as you can see, the MACE, expanded MACE, death from cardiovascular cause, death from any cause are all equal in the groups. There was MACE, expanded MACE, deaths from cardiovascular cause, deaths from any cause are all clearly equal in both the groups. The mean change of hemoglobin from the baseline of darbepoetin versus vadadustat also was similar. They came out with the in the same issue. They came out with the PROTECT study of vadadustat in anemia and non-dialysis dependent CKD. This is again two open label non-inferiority phase 3 trials of vadadustat versus darbepoetin non-dialysis patients. Hemoglobin were less than 10 in those who are not previously treated ESA, or less 8 to 11 if they were already on ESA. There was some variation between countries. Again, the safety endpoint was the primary time to event analysis, and secondary endpoints were also similar to the previous study. And the primary and key secondary efficacy endpoints were the mean change of hemoglobin between weeks 24 to 36 and 44 to 52. And there were the groups had 1,071 patients, ESA untreated, and ESA treated patients. So here the pool analysis again show the US population, non-US population, all were kind of similar to each other. In the MACE non-US population, there was the hazard crossed 1, which was a bit of a surprise. Apart from that, all the other populations were kind of similar in the two groups. So the non-US population alone was stood out as being different, and you're not very sure why. There's the expanded ACE also being just beyond 1. So the mean change of hemoglobin was exactly the same in the groups. The ASCEND D trial was from daprodustat, the next molecule, again 2020-21 in patients undergoing dialysis, a randomized open label phase 3 trial of darbepoetin alpha, another one with the darbepoetin on those on peritoneal dialysis. The primary outcomes were change in hemoglobin or safety endpoint of a first occurrence of major cardiovascular endpoint with a non-inferiority margin of 1.25. So as you can see, the hemoglobin changes hemoglobin levels are similar, as were all the cardiovascular endpoints, major thromboembolic event, deaths from any cause. So they were all exactly the same. The ASCEND-ND was a daprodustat study in patients who were not on dialysis. This is daprodustat versus darbepoetin. Again, similar outcomes that they were studying mean change of hemoglobin or the first occurrence of any cardiovascular event. And as was seen in the dialysis patient, the non-dialysis patients also, the hemoglobin levels were similar, and the cardiovascular outcomes were all similar, as was death from any cause. The CKD progression was studied, and that also was another one of their outcomes, and that also was shown to be similar in the two groups, irrespective of whether they received darbepoetin or daprodustat. We have a molecule which was studied in India, and that is a molecule, that's the only molecule that we have now available, and that is the desidustat. This was published in the American Journal of Nephrology. The first study came out in 2019. The phase 2 randomized double-blind 6-week placebo-controlled dose-ranging safety and efficacy trial, in which there were 117 patients received 100, 150, 200 milligram of placebo. And this is the way they gave it. They gave either 100, 150, 200 or placebo. And they chose the patients who were iron replete. And the drug actually showed safety with benefit in improving anemia. So there was a mean improvement of hemoglobin of 1.57 in the low dose and 2.92 in the high dose group. And most people responded with all 2/3 responding in the 100 milligram group and 83% responding in the 200 milligram arms. Then in the 2022, last year, the DREAM-ND trial of certain anemia due to in non-dialysis dependent CKD patients, it came out, published in the American Journal of Nephrology just about a year ago today. 588 patients with hemoglobin between 7 to 10, where they gave either desidustat 100 milligram twice a week or darbepoetin once a week for 2 weeks for 24 weeks. And primary outcome was change of hemoglobin from baseline. And there are a number of secondary outcomes of patients with hemoglobin response. Change in hepcidin levels was something that they wanted to show, and they looked for, as well as VEGF and change in lipids and lipoprotein levels. And this is what they found. The hemoglobin levels were no different. The serum iron levels were no different. The ferritin levels were no different. The transferrin levels were they bifurcated after from week 8 onwards. This is the same thing: hemoglobin, iron, ferritin, and the transferrin levels, saturation levels bifurcated. So these are the parameters of the groups were similar in both the groups, and the adverse events are also similar. What they did show was the change in hepcidin levels in the two groups at week 12 and week 24, which is very interesting that they were able to show this in the DREAM-ND trial. The DREAM-D trial was a similar drug trial of the desidustat. Again, 392 patients, and published in the American Journal of Nephrology, they gave them either desidustat or erythropoietin in a dose-dependent value, manner depending on the previous erythropoietin dose. And the outcome was change of hemoglobin, and there were a number of key outcomes. Mainly the number of patients hemoglobin response. The TSAT was similar. There were no major differences in the adverse events in the two groups. The secondary endpoints did not show a change in hepcidin that was seen in the non-dialysis population. So that is the major difference between the two trials, that they did not see a change in the hepcidin value. Apart from this, there are a lot of other trials which I will not go through, and other molecules like enarostat, amorelostat, and a lot of trials have been done. I've just tried to list a few of the more common ones. More and more studies have replicated roughly the same information. So I just want to conclude by quoting a few things from this last article of 2020, or when this meta-analysis of the RCTs came out, and they showed that the drug favored over placebo or the control, whichever they used, in terms of its efficacy, and either even if there were ESAs or there were placebos. So the drug clearly works, and overall there may be a slight advantage over the ESAs as well, as can be seen in this meta-analysis, but that was not individually shown in any of the trials. The correction conversion groups also all favored the drug, and the dosing frequency schedule is roxadustat is twice weekly, daprodustat, varolostat, and molidustat and enarostat are all once daily. What we have in India is desidustat, which is alternate day currently. However, as said in the Merchant of Venice by William Shakespeare, all that glisters is not gold. All that glisters, or as you say in modern English, all that glitters is not gold. So before we close and say everything is hunky-dory, we need to know that there is a debate on this drug and its potential bad effects that we need to watch out for. So this very interesting paper, debate or perspective, came out in the American Journal of Nephrology, exactly a year ago, published online April 22nd last year. And the author highlights that there are cautionary statements, but these statements, to be fair, came out before the major trials were published in their societies, the National Kidney Foundation, as well as the Asian Pacific Society of Nephrology. The other societies haven't been so forthright in coming up with these guidelines, but this is good for us to remember as well. So they warned against the progression of malignancy, again, not seen clearly, acceleration of diabetic retinopathy, abnormalities of liver function, hyperkalemia, decreased blood pressure control, changes in cardiac function due to pulmonary arterial hypertension, thrombotic events, increased cystic sizes in polycystic kidney disease, kidney fibrosis, and immune disorders. These are a list of things that they wanted everyone to watch out for, not that they were seen to be more commonly occurring in these trials. So while at no time can we say that these things do happen, it's good for us as practitioners of medicine and nephrology to be aware of these potential side effects that we need to watch out for, and be cautious in giving it to patients who've got very advanced malignancy or advanced retinopathy, for example. And they also had a very interesting table, so I thought I'll just bring it up. So when the drug was touted first in 2018 versus the reality check last year, the touted promises versus the realities, it was thought that there'll be lower plasma ESA levels, would decrease the ESA off targets, improve MACE outcomes. That is not true, and we did not have MACE non-inferiority in any of the trials, in most trials, sorry. The decreased ESAs off-target effects of MACE would allow for higher hemoglobin targets and improve quality of life. That's not true. No improvement in quality of life has been shown. Neither have they been shown to have higher hemoglobin targets. That actually has not been looked at in any of the trials. We've not aimed for higher targets. Improved iron mobilization, decreased IV iron requirements in patients. That may be true, not clearly shown in any of the trials, but we're not very sure whether it's an improved outcome is the author's perspective. Improved iron mobilization, ability to achieve target hemoglobin in ESA hyperresponsive patients. That may be true, but no studies done to target ESA hyperresponsive patients. But we've all experienced patients, and many of my colleagues in India have also said about how patients who are EPO hyperresponsive or not responding to EPO have done, or with suspected pure red cell aplasia, have surprisingly done well using the HIF-PHI. So this is a picture from the same article. The devil we know, whereas the devil we don't know. As the British are fond of saying, there is no free lunch. Everything comes at a cost. But in overall, it seems like these newest kids on the block are a game changer, but we need to watch out for potential adverse effects and use them with caution, especially, I would think, in patients who've got malignancies or at risk, very high risk of progressive diabetic retinopathy at the least. Thank you for your patient listening, and I'm happy to take questions if there are any. Thank you.
Thank you so much, Professor Santosh. This was a very detailed presentation. And as you correctly said, these molecules are turning out to be quite the game changers in the management of anemia and CKD. With that, Dr. Lloyd has got the ball rolling with two questions, and he would like to know, in head-to-head trials, what would be the preferred molecule?
In head-to-head trials, what would I'm not certain I understand the question. Like, what would an individual prefer in terms of usage? Is that the question?
Yeah. If you have to compare, there's so many molecules now. Are there any head-to-head trials? Number one.
Oh, okay.
And,
between the HIF-PHIs. Okay, sure.
Yeah.
Right. There are no trials comparing these drugs head-to-head. We'll have to go by what's available. So roxadustat was a molecule that was supposed to come into Indian market first, but then when the desidustat, the molecule that we do have, came up with such a quote unquote ridiculously low pricing compared to the Western counterparts, they had to withdraw their plans of promoting it. So we don't have any of the other PHIs in our country at all. So I think whichever is available, we would use. The ease of convenience of desidustat is that, and roxa is that you can give it less frequently rather than daily.
Thank you so much. And Dr. Lloyd's second question is, what would be the economics of these drugs to use? Will the generics come on board at any point?
In a sense, while not a generic, the company that has brought out desidustat in India is a company that has brought out a lot of generics in India as well. So they aimed at bringing in a pricing which is quite low. It's comparable to a generic erythropoietin or a darbepoietin. That's the beauty of it at the moment for us in India. Our patients love it because it's oral and it costs the same, no injection. So they love it. Yeah, not that it's wiped out the ESA market entirely, but I think a lot of patients are preferring it. At least the non-dialysis patients are preferring it.
Thank you so much. So while we prepare to take Professor Bhima's question, I would like to invite the panelists to also unmute themselves and ask Professor Santosh their questions, and also the attendees could use the chat boxes, the Q&A chat box or the regular chat box to post your question, and we will read it out for Professor Santosh. Or also feel free to raise your hand and we'll give you a chance to unmute and talk and ask your question to Dr. Santosh directly. Professor Bhima, can you ask?
Thank you so much. Santosh, that was a wonderful presentation. I really enjoyed it. My only question from a pediatrician's point of view is, any trials in children? Because I know we were supposed to run a trial on roxadustat here in South Africa, but something went wrong and there was some licensing issue, etc. And so we came off that panel. But have India or any other place done pediatric trials, is it?
No, no, unfortunately not. I think what will find is we'll have people writing case series of how they've used it in children.
Yes, off-label
And
use.
yeah, so I do see some children. I've got, I think, 1 or 2 children on a very small dose of deslizate, like 25 milligrams. I don't remember how old the child was, but it is not a very small child. It was a child more than 10 years of age.
Okay.
And N is equal to 1 or 2. Yeah.
But I mean, have you seen a good response, right?
Yeah. But it is early days yet. I haven't used it for many years. It's just a few months into the use. Yeah.
Okay. No, thanks. That's great.
Thank you, Professor Bhima. So we have a question from Dr. Mazhar Amir. He's a nephrologist in Tanzania, and he's seeking your opinion on switching patients on EPO to HIF-PHI once they become readily available, and should they be switched, especially if the hemoglobin is stable in that condition?
No, that's a very good question. See, the question is, should you switch? I'm not certain of the answer. So my patients who are taking either darbepoetin or sera or erythropoietin, I don't switch them. Why do you want to switch them? The patients are saying, can I go off injections? I've heard there's something available. By all means. Or if they're having EPO or hyperresponsiveness, by all means. But just for changing to an oral one, if somebody is doing well and is comfortable taking the injection, we have a preparation in India which comes as a pen device. It looks like an insulin pen. It's got 30,000 units of erythropoietin. It's the Wockhardt company's VPOX pen. So patients inject themselves like they're injecting insulin, especially the ones who are on insulin. They find it very convenient. They keep it in their fridges, they inject themselves. And people who got used to it, I don't think we should change. But places like our country where cold storage of storage level 4 degrees is a problem in many places. Transport and cold chain maintenance is an issue. In all those places, this is absolutely a game changer.
Thank you so much. And there's one more question from Dr. Lloyd concerning the combination of longer-acting ESAs, potentially with HIF inhibitors, and possibly just to decrease the adverse events involved.
That's a very good question, and I'm sure nobody systematically looked at it. We had a patient who recently had a transplant who was on both. In our minds, you're wondering whether it's illogical to do it, but this patient had a marrow which was slightly hypocellular, was having anemia because of and EPO hyperresponsiveness, so was on a strict dose of darbepoetin and the desidustat around I think it was 100 or 150 thrice a week. So it's we were wondering whether we're doing something wrong, but we want to just be sure everything was all right. So before transplant, to keep the hemoglobin up without transfusing. So we went ahead and gave this for this patient. So that's all I can say. No literature on it at all.
Thank you. Thank you very much.
So there's a very sharp observation, Prof, from one of the attendees, and he said that it's very clear that the molecule works. So why are there so many trials for the same?
I think we have to before the US FDA approves the molecule, they have to demonstrate its efficacy, safety in multiple studies and so on. And with all that, I believe it's only daprodustat which has been approved as of now by the FDA. They don't think Roxa, which came first, has yet got the FDA approval. So despite all the trials, it's not a foolproof. They're not. I think they are writing white papers to the FDA and so on. I think it's in the pipeline, but it's not happened yet. I think only daprodustat is in the non-dialysis population is the only one that's got FDA approval as of now. If I'm right, I may be wrong, but I think that's right. That's where it is at.
Thank you so much. And another question is there a specific target for hemoglobin, or do we aim for the maximum level as we do for EPO?
Well, that's not been looked at separately. I think they've generally tried to keep the same as for erythropoietin, darbepoetin, sera, maintaining the 10.5 to 11.5 or 11 to 12, like for all CKD patients. I think they just gone by that. I don't think they've targeted a lower level in these patients or a high level, saying it's safer because it's not erythropoietin, therefore the deleterious effects are not there. Let's target a higher hemoglobin. That also not been looked at. Maybe in coming years they may, but as of now we don't have the information.
And again, someone is seeking a clarification on the nomenclature of the trials, the DREAM, the Himalaya, and he's asking for the meaning for the same.
I'm not certain. I know. Actually, I did not look at whether they all are acronyms. Most of the early trials on the HIF-PHIs were named after mountain ranges. I think that this company just went with it, and I'm not very certain why the Indian company wanted to call themselves a DREAM. Maybe I don't know. I don't know. Maybe, I don't think there's anything very scientific to their nomenclature.
That's fair enough. That's fair enough, bro. We do have one more question, and this is from Dr. Akrabi. So for non-dialysis patients who haven't started erythropoietin, is it safe to start them on HIF inhibitors once available?
I think so. I would think so. I would think that just similar to our regular doses, regular erythropoietin, darbepoetin, and sera, we can give them doses as required. I haven't really come to a grips with how much to prescribe for each patient, because I'm still cutting my teeth on it. For the low hemoglobin, meaning lowish hemoglobin 9-ish, and giving them 200. Slightly higher. They have used a rationale in the trial, but I have not been strictly following that rationale, because that requires a follow-up, sometimes not always possible. So I started slightly higher doses and asked people to check locally and adjust accordingly.
Thank you so much, Prof. We still have a few minutes to go in case anybody else has another question. I think Dr. Mazhar, Dr. Akrabi's question was along the lines, and probably that also answered your question as well.
One question more. The rate of rise of hemoglobin, now when you compare the ESAs against the HIF inhibitors, is it different or is it more? Is there any sort of study on that?
So, Dr. Lloyd, the graphs all seem to look identical in terms of the rise of hemoglobin. They were not very different. So I think patients who, it just works similarly, I think it's just another alternative. I think their thought process was that they could rise faster, they could tolerate a high hemoglobin without adverse effect. That we don't know yet.
Thank you very much, Prof. So for our audience, since Professor Santosh is presenting from India, it is actually 10:30 in the night there, and he's been very kind to stay up late and answer our questions. So I'd just like to thank Professor Santosh once again for taking his time out, talking to us once again, and I'm looking forward to talk number 10, 15, and 20 in the coming years from Professor Santosh. And I'd also like to, for the Tanzanian audience who are attending tonight, claiming CPD points, the link for the CPD points questionnaire is on the chat box. So you can access it and fill out your form, and you will have access to your CPD points. Also, we will have this talk up on YouTube by next week on our channel, AHN Fireside Chat. So please do check it out once it's available, along with the other 100 videos that we have already put online. With that, I'd like to invite Dr. Lloyd to come in and give a vote of thanks for Professor Santosh before we wind up the session.
Yeah, without much time, I suggest, it was a wonderful session, a very, very important topic, and really something that we really look forward to in the African side, and all the experiences that you've had with using the molecule there. So I think a lot more needs to be unveiled, but I think it's a very, very interesting and wonderful session. Thank you so much, Santosh.
Thank you very much for the invitation. I'm happy to always participate. It's nowhere near my bedtime. I don't sleep before midnight on most days, so it's all right. Just to add to the topic, there is a phase 4 trial which is starting in our country in I think around 27 or centers or 33. Anyway, it's a large number. So looking for safety endpoints. So I think that will answer a good question for us and be very meaningful for our country and Africa as well.